if you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Jacob, do you remember this episode?
Whoa, that was a long time ago.
Yes, it was.
That's episode 5?
This was episode 5, which I can't even remember what we did before this, but I can't believe we talked about.
Were you guys residents?
No, we were done with fellowship. We were out and practicing as actual doctors, which is amazing. But this was literally like one of the first episodes we ever did. It was with Vicky, and we talked about hernia ultrasound. And this was when was this? This was a long time ago.
But it was a long time ago. I mean, look at your face. Is that even you?
Is that even you? Are you? So, I guess basically what I'm getting at is I feel like it's been a minute, and we haven't talked about the poop sac in a long time, which I think we probably need to readdress the poop. And wanted to talk a little bit about hernia because I had this case recently. So let me tell you about this case. Let me tell you about this guy. This guy came in. He had belly pain. He was, 50-ish years old, and was basically like, telling me that his hernia was stuck out. It was stuck right out of his belly, and he couldn't get it back in, and it had been stuck for like a week. It's a long time, right? I mean, like, that when I hear a week, that kind of freaks me out a little bit. And his stomach looked a little bit like this. He had a umbilical hernia, and it was fairly large. It was not a small hernia. He didn't really look sick though. Like he looked fairly well, right? Which is a little surprising if somebody's had a hernia stuck for that long. Right. So I think you could probably imagine what I did. I did some ultrasound, and this is what I saw. So what do you think I'm seeing here, Jacob?
So that looks like an abscess. It's definitely not.
This is not an abscess, not in any way, shape, or form an abscess. No, it's close. So it's close, but really, really far off. So this here is
it's
bowel.
Close if you want to be 100% wrong.
Right. This is bowel, right? So here is your poop sac. Okay. You can even see your poop sac kind of coming into the screen, right? There's like that right there. See that? Yeah. And there's there's a break in the fascia, right? In the midline, probably some rectus muscle on this side, some rectus muscle on the other side. There's a little bit of fluid in the hernia sac. And there's even like a little bit of like maybe ditzels of air in the bowel. What do you think?
Oh, wow. So you talking about like in the bowel itself or in the bowel wall?
I don't know. That's a good question, right? I mean, like, but
bowel wall would be bad, right?
I mean, you're kind of the air guy. You know about air. You do the lung ultrasound thing. Does that look like air?
I do lung stuff.
You do lung stuff.
It does look like air. It looks like a little like ditzel of air for sure.
So I thought, all right, well, I guess I need to put some color Doppler on this guy. So what do you think about the color Doppler image that I'm showing you here?
I think what I'm supposed to say is that there's not a whole lot of flow in the walls. Is that right? Is that what I'm supposed to say?
No, I don't know that. I mean, I'm not sure. So to be honest, I'm not sure exactly what I'm looking at. But what I will tell you is that what I did see in this image is I see some peristalsis in the bowel, right? And I see what looks like probably some regular Doppler flow that would suggest there's at least some arterial blood flow in this bowel, plus peristalsis, right? But at the same time, there's like kind of this fluid in the hernia sac, and there's some air. Is that air in the bowel? Here I've got a good view of the hernia sac. You can actually see
so awesome. Look at
some color Doppler going into the bowel, which I think is probably a combination of arterial flow and also like poop actually entering the poop sac. So I think we're actually seeing like some of this peristalsis is creating Doppler flow going into the poop sac, right? But then there's also all this free fluid in the hernia sac and a little bit of echogenic fat in the hernia sac as well, which had me like a little nervous, right?
Sure.
So I guess my point here is this is a sort of an unusual presentation, and I don't exactly know what's going on with this bowel. Like I think there's some Doppler flow, so does that mean it's not dead bowel and I can push it back in?
I don't know, man. That free fluid makes me nervous, and the fact that he's had it out for a week makes me nervous. I would not push it back in personally. I'd call surgery.
Gotcha. And then I looked at the rest of his stomach because he was complaining of a little bit of distension, had one episode of vomiting, and this is what I saw. What do you think's going on here?
That looks kind of weird. Can't really see if it's That makes some poop in there. It looks like it might be a little bit dilated. It's like probably about 2 centimeters.
Yeah. So this one is dilated. It's like a little over 3 centimeters in dilation. Like if you look over here, 1, 2, 3, right? So about 3 centimeters. And then I don't know if you can tell, but there's some poop going back and forth inside that bowel. And then I also kind of felt like there's like these little distils of air right here. And I'm kind of thinking like, is this in the bowel wall? So I guess my whole point here is that this one wasn't really clear. And I got to be honest, I was kind of trying to remember like what are the criteria for strangulated versus incarcerated bowel, and how do I treat them differently, right? And how do I tell with ultrasound? So we ended up getting a CT on this guy, and he ended up having actually healthy bowel with necrosis of the hernia sac. So like the sac that was protruded out was necrotic, which is why he had all that fluid in the hernia sac.
That was like a thing.
Yeah, it's a thing. I didn't either, man. Yeah, sometimes you learn stuff. It's crazy. but the bowel was okay, which is probably why there's peristalsis in it and Doppler flow in it, right? So this just got me thinking, like, I probably need to readdress hernia ultrasound, not just for myself, but it'd probably be good to redo it on the podcast and just kind of talk about it again, because I think we've all got a little bit more experience with it now that we've been using it for a few years now. And the data, if you look at it on ultrasound for hernias, is actually really nice. So this is an article out of the Royal College of Surgeons in England, and they found a 100% sensitivity and specificity for all hernias. And then if you break them down to direct and indirect, then it's, sensitivities and specificities are a little lower. But these are radiologists. These weren't emergency docs, right? And it's 2003. Another one, systematic review and meta-analysis from 2013 found that ultrasound has sensitivity of 86% and specificity of 77%. Now, this was specifically in occult inguinal hernias. So these are not necessarily the patients that we're seeing in the emergency department. It would be somebody who comes in with lower right lower quadrant or left lower quadrant pain that's, doesn't have an obvious hernia on physical exam. But the thing that was interesting to me is that ultrasound was almost as good as herniography, which has got to say something for ultrasound. It's almost as good as the exam that was created to diagnose hernias. So I got to say that, the data would suggest that ultrasound's very good at finding hernias on people, at least compared to the gold standard of CT or herniography, right? And there's been a little bit of research on this in the emergency medicine literature, but it's almost all been case reports. So there hasn't been a really good trial saying, emergency physicians are very good at diagnosing hernias on ultrasound, but there have been some case reports saying like, hey, look, we can actually do this, going back all the way to 2002, and then some more recent ones in 2015 and 2014. And the reason I think that we are good at this is because, for the most part, it's fairly easy. You're looking very superficially, right? So we're just looking for a defect in the fascia, right? And we're looking for bowel sticking out of it. And it's not actually that hard to see, right? And in some ways, I feel like this is a lot like small bowel ultrasound, because we're just looking for this very obvious structure sitting right there, superficial to where we would expect to see bowel, right? Yeah. Here's an example of one here. So we're sort of scanning through the poop sac in this case. And this one's a pretty sweet one because you can see the flow in it really well.
Yeah.
It's fairly obvious when you've got a piece of bowel sticking out of the peritoneum up in the soft tissue. I mean, look, we're the bowel here is 3 millimeters from the skin or something like that. So it's really pretty obvious. So I want to talk for a minute, Jacob, about finding the poop sac, because I think that there's some benefit here to knowing how to diagnose these hernias with ultrasound, because in my experience, the hernia exam can be a lot harder than a physical exam would lead on to make you believe, right? We kind of talk about diagnosing hernias on the physical exam in medical school. It's a super easy thing to do, but in reality, it can be kind of tough, right? Not all your patients have a BMI of 25. I don't know.
Right.
So when it's, it's something obvious like this, or one of these guys, I think we probably don't need ultrasound to make the diagnosis, but sometimes things are a little bit more challenging, right? Not everybody's going to come in wearing their hernia support so that you know exactly where to put your hands, right? This reminds me of that thing you were wearing the other day, Jacob. Is that?
Yeah, that's called a C-string. guess you're wondering.
I thought it was very nice. I like the color choice too. So part of the problem here, I think, is that these patients can be, obese. Their abdomen can be a little bit large, and it can be hard to get a good physical exam on them. So it's nice to be able to just throw the ultrasound probe on and then, sort of make the diagnosis that way. So let's talk for a minute about the different types of hernias. We got femoral hernia, we got direct and indirect inguinal hernias, and then we got like the umbilical hernia, which are usually fairly obvious, and then incisional hernias, right? Familiar with all these?
Man, I always get confused about like the difference between like direct and indirect, which is like.
We were talking about that. That's perfect. I'm like really good segue. If you had just said like, it's like, I really always wanted to know how to diagnose a femoral hernia, that would have been an even better segue. Let's start with one that I personally have actually never diagnosed. Have you ever diagnosed one of these, femoral hernia?
No, like not even without ultrasound, like since I've been out of med.
Let me restart that question. Did you know that femoral hernias existed, Jacob?
I feel like they're one of those like diseases that you learn in med school but don't ever see. But don't they talk about like, this being like fairly common in females? So I've probably missed this like 100 times.
Yeah, so this is an interesting one because I feel like it's super easy to diagnose on ultrasound, like so much easier than physical exam. Like I think the physical exam here is super challenging. So let's talk about it real quick. All of our exams are going to be done with the linear probe, right? Because we're talking about really superficial stuff, right? If you're looking for a hernia on somebody who has a BMI so high that you can't see it with a linear probe, I think that person probably needs a CT scan. But in this case, seriously, in this case, we should be using the linear probe. The nice thing about the femoral hernia is that it's an exam that we're familiar with. So what you're going to do is look for the common femoral vein, and you're going to look for where the saphenous comes off of the common femoral, okay? Then you're going to look medial to that common femoral vein just above the saphenous and have the person perform a Valsalva. And when they perform that Valsalva, what's going to happen is this big hernia is going to protrude down right next to the common femoral vein, right? So this is one of those exams where it's all about being dynamic, right? So the person's completely calm, cool, and collected. There's no abdominal pressure. They perform a Valsalva. They push the bowel or the fat or whatever it is down near the femoral vein, and you'll see a big protrusion down there, which is the hernia, right? And we're going to use that for all of our hernia exams on ultrasound. Now, if this person had an incarcerated or strangulated femoral hernia, that would obviously be like this all the time, right? So like on the right side here where you've got this giant hernia, that's always going to be stuck there and it's not going to change with Valsalva, right? But we're talking about the non-incarcerated, non-strangulated hernias. So now let's talk for a minute about the direct and indirect. And I got to agree with you. I always forget the difference between the two here, right? So the difference is the direct is the one that comes through that triangle. Remember that triangle in medical school, like the iliac and the rectus sheath and the epigastric artery. Remember all that stuff? Direct comes right through that.
Vaguely.
Yeah, direct comes right through that. Indirect comes up out of the deep ring of the inguinal canal and then goes down the inguinal canal down to the scrotum, right? So that's indirect. Whereas direct like pooches straight out, okay? So the way we diagnose these on ultrasound is by finding the epigastric artery and vein because they're going to be like our key factor for finding these guys. So you're going to want to take the probe and put it right over the epigastric artery at the level of like the rectus muscle, and you'll find the epigastric artery running posterior to the rectus muscle, and then you're going to track the epigastric artery and vein inferiorly down towards the inguinal canal. And you don't really need to like think about what you're really seeing on the screen other than the fact that you see the actual vessels themselves. So find it under the rectus muscle and then run inferiorly along the epigastrics, and you should start to see the hernia itself popping out. Now, as you make your way down, what you're going to want to do is have the person basically Valsalva. And as they Valsalva, when you're over the epigastric, here we've got the epigastric vein in view, right? You should see something pop into the image, and it happens to actually be shit. So what you're seeing here is now we've got an image, right? We're down low in the abdomen, and the only real structure that you've got to help identify where you are is the inferior epigastric, right? In this case, they've labeled this as the inferior epigastric vein. You might see both the vein and the artery, but basically what's going to happen is this big poop sac is going to pooch out right next to the inferior epigastric vein. Now, for a direct hernia, that's going to come medial to the epigastric, whereas an indirect is going to come in lateral. So let me show you an indirect real quick. Does it matter that you remember which one of these is which? I'm not sure that it really does. But basically, here's an example of an indirect. And in this one, the bowel is coming up through that deep ring, right, of the inguinal canal, medial to the femoral vessels. This is a femoral vein over here. Here's the inferior epigastric. It comes in between the femoral vein and the inferior epigastric, and then starts to make its way down the inguinal canal. So we're actually seeing it go down the inguinal canal right here. And this is what happens.
Awesome.
This is what happens with.
So is this probe like
Valsalva.
diagonal? Like how's the probe?
It's pretty it's pretty axial in this case.
Okay.
Yeah, so you've got an axial plane. You've basically taken the probe and just started here behind the rectus sheath, and you're just tracking the inferior epigastric down. And as you track it down, you might even get to the point where you see it come into the femoral vessels, right? And then you know that you should be at the level of where the inferior epigastric inserts into the femoral vessels, or superior to it, where it's tracking right next to them, going up under the rectus, right?
So like a good landmark is, it seems like, is to make sure that you know where the inguinal canal is, right? Because, well, I'm wondering because that's the same place that you said like a femoral hernia would be. Not
really, because the femoral hernia is going to be deeper. It's going to be where the greater saphenous comes off of the common femoral, right? So we're more superior from that now. We're up near the inferior epigastrics, right? So you're a good bit higher up. I mean, if you just think about it like anatomically on the patient, assuming you can kind of like see what's going on, you're a good 3 or 4 centimeters at least inferior for a femoral than you are for inguinal canal.
Yeah, I got it. That makes sense.
I mean, either way, though, you diagnose a hernia, and at least you've got an answer, and you know what the appropriate follow-up is, right? All right. So, last one to talk about, Spigelian, which is.
I've seen this spelled like 7 different ways, like in your slides.
I was kind of hoping you would notice that. I couldn't remember how to spell it, so I just spelled it all the different ways I could think of. This one is maybe the most ridiculous.
Okay, wait. Before we talk about whatever it's called, go back and make sure you're watching the last few minutes. Why? Well, because Mike totally screwed up his words. Not great with the English. Luckily, we added subtitles to translate, but you need to watch it. Then we're going to do this, whatever it's called, next time. And even more importantly, we're going to go way beyond diagnosis next time. We're going to answer the questions: is it incarcerated? Does ultrasound good for this? And what to do. In the meantime, if you want to learn this in person, go to castlefest2018.com and register to hang out with us in a castle while learning super dope ultrasound skills.
if you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.